Welcome, everybody. My name is Jared Wesley, and it's my pleasure to welcome today's event on healthcare reform, brought to you by Edmonton Regional Group of IPAC with our sponsors, PwC Canada. For those of you that might not be familiar with IPAC, it's a dynamic association of public servants from all orders of government across Canada, as well as academics and others that are interested in public administration. The Edmonton Regional Group is one of 18 IPAC groups across Canada with more than 700 members, and we're the second largest regional group in the country, with members from the provincial and federal government, the cities of Edmonton and St. Albert, Strathcona County, County of Leduc, just to name a few, and we're growing by the day. Our goal is to bring together new and experienced public servants, academics, and others in our region to promote public service innovation, to foster collaboration, and to recognize excellence in public administration. We do this in a variety of ways, including this new webinar format. And we're glad to have our partners, our hosts here today, PwC, to help us to provide this kind of quality programming for our members and for the general public. We'd like to thank PwC Canada and MNP for sponsoring our events throughout the year. For more information on IPAC, I encourage you to visit ipac.ca/Edmonton. Turning to today's event, we're fortunate to have Dr. John Church with us to discuss his co-edited volume, Paradigm Freeze, Why Is It So Hard to Reform Healthcare Policy in Canada, which is published by McGill Queen's University Press and produced with the Institute of Intergovernmental Relations. The book examines the disconnect between the salience of healthcare as a political issue and the scope of government-sponsored reports into the issue on one hand, and the lack of healthcare policy reform on the other. John's here to present findings on behalf of his fellow editors and contributors, and we're really happy to have him here today. For those of you that don't know John, Dr. Church is an associate professor in the Department of Political Science at the University of Alberta. Since the 1980s, his research interests have revolved around the role of institutions, ideas, and interests in healthcare policymaking. He's taught health policy at the University of Alberta to physicians, nurses, health managers, and social scientists and social science students since 1994. Dr. Church has worked with international, national, provincial, regional, and NGO health agencies in the evaluation of health programs and healthcare reforms. In 2012-13, he appeared as an expert witness before the Alberta Health Services Preferential Access Inquiry. He's currently working on the first of 2 books on healthcare in Alberta, and I'm sure there'll be lots of interesting new chapters to come with the political climate the way that it is. For those of you that are tuning in online, either live or afterwards, please feel free to send us your questions or comments using the hashtag Paradigm Freeze. And with that, I'll turn it over to John.
Great, thank you very much, Jared. So, the project that we undertook started back in 2000, and at that point in time, we approached the Canadian Institutes for Health Research for funding, and we did not get funded the first time around. We had to go back for a second. Well, they gave us some money the first time around, but it was really to develop a proposal, and then the second time around we got funded. And I was, pleasantly surprised that we got funded, but to be honest, several of my co-authors on this book were actually involved with the Canadian Institutes of Health Research. So I think that their expertise in being able to navigate things through the process probably helped us somewhat. But in retrospect, and looking at what has happened to granting agencies since that time, my guess is that a project of this nature probably would not be funded through CIHR ever again. Subsequently, we managed to get funding from Health Canada and the Canadian Foundation for Health Innovation. That was towards the end of the process when we were looking at trying to put a book together. But the project itself was originally conceived as taking around 4 years to complete, and it took us basically well over a decade to complete the project and get a book produced. And part of that has to do with the fact that the type of research we were conducting is very labor intensive. and that it does require the cooperation of a huge number of people in order to carry the research out, particularly the people that we relied on for detailed information about what was going on in the various jurisdictions. So I think one of the lessons that I've learned from doing this kind of research is that it takes a long-term commitment, and something that research granting agencies probably should keep in mind is that these sorts of projects do not normally fit into the kind of time horizons that the research granting agencies are using. Having said that, we were able to produce what I consider to be a fairly substantive piece of work, and a lot of that has to do with the combination of people that came together on the team. And I have to give a huge amount of credit to Harvey Lazar, because Harvey basically was the guy that had to herd the cats, so to speak, on an ongoing basis and deal with the particular needs and preferences of the various cats. And as time went on, that of course became increasingly difficult because the cats started wandering off onto other things once the cat food started to disappear. The second thing that Harvey was essential in doing was actually pushing us all intellectually. We were the ones that were more embedded in the academic process than Harvey was actually, but Harvey, quite frankly, he's got a beautiful mind, and the fact that he pushed the analysis and pushed to get this book done for as long as he did, he deserves a huge amount of credit for that. So I didn't want anybody here or anybody out on the internet to think that I was sort of the mastermind behind this book. In fact, I consider myself to have been in the midst of a number of great intellectual minds around health policy, and it was a great privilege for me to actually have the opportunity to interact with those people over a long period of time. I learned a huge amount from them, and for that I will be forever grateful. And tip of the hat to Alan Tupper, who some of you may be familiar with, who's now at UBC, who put Harvey on to me at the outset of this process. And I think it was Alan's recommendation to Harvey really that got me into the loop with this group of distinguished academics. So there you go. What was the book about? Well, we wanted to know why it was so hard to achieve real health reform. We didn't want to start out by expressing our personal views or even our academic views about what we thought reform, what real reform should look like, whether or not it should be more private market or whether it should be, more public sector involvement, or what that configuration was going to look like. We didn't want to set out, and quite frankly, if you'd gone around the table in the room, you probably would have found a diversity of opinions about that anyway. So it was not our intention to sort of start out from a prescriptive point of view. It was our intention really just to ask the question, why is it so hard to get real reform? And then to look at what kind of reform and how much reform had occurred in Canada. Because while our book kind of says, we conclude that not much real reform has occurred by the standards that we established, we know that reform, quote unquote, is happening on an ongoing basis all the time at various levels in the system. How successful it is or how substantial it is a matter of opinion. And it's also a matter of, against what standards do we determine what real health reform constitutes. So, part of what we played around with in terms of developing the methodology for this was how are we going to, somehow assess the reform that has taken place, somehow determine, against what benchmark, and then having done that to say, okay, so we know that in certain cases there seemed to be more reform than in other cases. So what would explain that? So what conditions were occurring out in the environments at that moment in time that that might have contributed to those sorts of reforms happening? So that was kind of where our methodology, how our methodology evolved. And we didn't start out, when you look later on in the book at the different ways that we slice the data, so to speak, we have several chapters analyzing the data from different perspectives, looking back historically, so comparing our period with previous periods and then projecting forward into the emerging period. We looked at whether there was a difference based on the ideology of the political party in power, so whether a left-wing party was likely to do things radically different than a right-wing party, all those kinds of things. Those were the sorts of things that emerged later on when we were sitting down to think, well, okay, so this is our preliminary analysis based on what we started out thinking. Are there any other ways that we can look at this? Because we were somewhat concerned that because our approach was qualitative in nature, that we would be that we might be challenged both in the intellectual community but also out in the broader policy community as, well, qualitative research, this is all very good, but. So, so there was a certain sense of wariness about moving forward before we had sort of done as much with the data that we collected as we could possibly do. And again, a lot of credit goes to Harvey for being persistent. We were kind of the ones, some of us being more directly involved in the health services research community than others. We were the ones that kind of started, we're forever being, leery about moving forward on things. And Harvey, reading the room and all this stuff, said, well, okay, then I guess we're just going to have to make sure that our analysis is as thorough and multidimensional as possible. And that's how we kind of got to where we were going with the analysis that emerged at the end. So the kinds of reforms covered, macro health policy reforms in the areas of governance, finance, delivery, and program content. So we did not cover micro reforms. So my earlier comment then about how we all realize that reform is going on all the time at various levels of the system. So down at the level of the operational level, there are forever incremental reforms going on. But that was not really the focus of what we were doing. We were looking for higher level policy reforms that might result in fundamental changes occurring in the healthcare system. So we had 30 cases across 5 provinces, 6 per province. So each province then had 1 case around governance, and it was regionalization, and then we had some finance cases, some delivery cases, and some program content cases. And I'll come back to that a bit later. So the extent of reform between 1990 and 2003, up to 30 cases, we found that in 17 cases we had no reform or limited reform by the standards we set up. And the standards that we used at the end of the day were to look at the published gray literature and the academic literature about what the consensus was around a particular policy area. So governance, for example, what was the consensus from the gray literature and the public and the academic literature about what would represent real reform? In other words, what was the destination that the literature was telling us we should be aiming for? And so we used that as establishing our benchmarks and then ratcheting back from there. So if they achieve some part of that, then it might be, it would be ranked somewhere along a scale, so to speak, of how much reform had occurred. And only in one did we see comprehensive, and that was in Quebec's efforts to reform its drug plan. So everything else we did not really see as being comprehensive in nature. There were 6 cases, though, where significant reform had occurred, and regionalization in Saskatchewan and Alberta were 2 of those cases, right? So, and then we saw meager outcomes that were really consistent with what the literature said. So that was kind of the scale that we established, and the details of that are laid out in the book in quite a bit of, with quite a bit of information. So you can look at the book to get further detail on that. I don't want to spend a lot of time around this. I want to get to the discussion as much as we can. So the big picture then coming out of the book is that insider interests were usually involved in resisting or slowing the kinds of changes that represented fundamental change. And they ultimately played a significant role in shaping the reform that actually took place. So in particular, physicians were a privileged group in this respect. The main pressures for reform, on the other hand, came from things that were basically outside of the healthcare sector. So downturn in the economy. I'm not going to mention the price of oil and gas, but that's certainly something that's specific to Alberta, and newly elected governments. And the dynamics around newly elected governments was quite interesting, and it was quite telling, particularly in the case of Saskatchewan. So the main findings and the exogenous factors, so factors outside of healthcare, new government and a fiscal crisis as opening a policy window, and the inside factors, so insider interests as resisting significant change. So in the case of Saskatchewan, Saskatchewan is probably the ideal case example of the things that can initiate reform. So a new government coming in who had run on a platform of significantly reforming the health system, who wins a mandate, they then assign a political champion to quarterback moving forward on that mandate of policy change, and they move forward quite forcefully to get as much done as they can. Alberta is another example of that, where while they didn't actually have a new government, they had a new political leader, who had not run on a platform of healthcare reform per se, but had run on a platform of general government reform into which health reform was then embedded. So Saskatchewan and Alberta really represent good examples of how that dynamic played out quite successfully. However, the limitation was that in all the cases, governments, when they pursued health reform, were only able to do it for a limited time period, and that was during the first part of their first political mandate. And after that, it didn't seem to make any difference. So in other words, Ralph Klein was elected multiple times, but his greatest reforms to the healthcare system, his greatest efforts, and the greatest movement towards implementing change in healthcare happened basically during the first 2 or 3 years of his first mandate. And after that, he was basically stonewalled and unable to do much of anything, right? And the same with Romano. He was most successful really in the first several years of his first mandate. And after that, it didn't really matter. So again, it may not come as a great revelation to people who have been involved in politics and have been studying politics for a long time. But it's kind of interesting to look at 30 cases and see that pattern kind of play itself out across all of those cases. So you can see cases where there was no mandate. For example, in Newfoundland, healthcare just was never on their agenda, right? Because they were concerned with trying to repair the economy after the collapse of the cod fishery, and that was their sole political item. Their sole political agenda was to try and deal with that. So healthcare was not even really on their agenda. So there was no political commitment really to pursue any real health reform. That's why Newfoundland comes out, compared to the other cases, Saskatchewan, Quebec, Ontario, and Alberta as the province that achieves the least in terms of any kind of meaningful health reform. So, and here's, first time government, campaign commitment, first half mandate, fiscal crisis near a perceived crisis, or civil public opinion pressure. And the civil public opinion thing came into play particularly around wait times. So wait times was one of our cases, and really government was driven in a lot of respects by the public opinion polls around their confidence in the healthcare system and their concerns about wait times. And of course, other organizations such as the Fraser Institute simply reinforced that by releasing quasi-academic kind of analyses to confirm that wait times were in fact a significant problem. So that basically, and it's interesting, you can look at, in the chapter in the book on Alberta, you can see the polling that Alberta was doing on public confidence in the healthcare system. You can see the downward spiral of that, during the 1990s and into the 2000s. So it was, quite consistent that people were just consistently losing confidence in the system, and government had to be interested in wait times. And I think, you look at other jurisdictions, it's a similar kind of situation. But certainly, it wasn't the financial crisis that prompted governments to do something about wait times. It might have, in fact, exacerbated the problem, but it didn't prompt governments to do something about it. And it certainly wasn't peculiar to any incoming government. So any new government with a mandate for health reform, they all had to deal with wait times. So that was kind of an interesting thing that came out of it as well. So as I mentioned earlier on, organized medicine of the insider interests is the most influential group. By far, they had an effective veto on any change that impacted the freedom of individual doctors to choose form of compensation. So alternative payment plans were another one of our case studies. In the case of APPs, while numerous reports have recommended that governments shift physicians off of fee-for-service for a variety of reasons, governments have moved very carefully on that. And in all cases, it has been done in collaboration with medical associations and through joint management processes. And by and large, those joint management processes have left a lot of control in the hands of doctors themselves in terms of implementing alternative payment plans. And alternative payment plans have been voluntary, right? So it has depended on uptake, on voluntary uptake by individual physicians, which, as we know, has not been to date as significant as politicians would have hoped it was going to be, right? Although, if you look at broader primary care reforms, there's lots of other stuff going on as well that maybe shows signs of more hope over the long run, right? I mean, it's complicated, as we know, right? There are a variety of other factors going on. We can get into a discussion about that later. But the bottom line is that government, while it's well recognized that changing the way we pay physicians would be a way to fundamentally reform the healthcare system, governments have not simply moved ahead and done that based on evidence alone. Regionalization is another interesting case in point where while from the point of view of those who were charged with managing regional budgets, it would have been helpful if they had also been able to include physician services in their budgets. No government was going to try to ram that down the throats of organized medicine at the time when they were also collapsing hospital boards and closing hospitals. So it was, as a policy idea, it was kind of dead on arrival, right? It was stillborn. And again, that was because the governments knew they would have significant pushback from organized medicine, and they probably wouldn't have been able to get regionalization done if they tried to include that as part of regionalization. And of course, to date, we know that we have not had physician budgets transferred from direct relationship with the ministry and the provincial medical associations. In the waitlist management case, which was also one of the ones we looked at, the big issue with waitlists was where they were kept in the old system, and that was in the pockets of surgeons, individual surgeons. So getting them out of the pockets of individual surgeons and into some sort of centralized database that ultimately might be publicly accessible, and certainly that would give the managers of the system much better information for planning than they had, was again a very politically sensitive topic, because it touches on the professional autonomy of physicians. And that's kind of the line in the sand that according to the original agreement that society made with doctors in this country, that's the line in the sand that you just can't cross, right? So again, waitlists, another example of where that veto was effectively used. So while organized medicine had an effective veto in a number of these areas, it was less successful in selling its own ideas, where their interests were not directly affected. So while some doctors were annoyed that they were not consulted before the regionalization process, it did not stop regionalization from actually happening. So, government or doctors were better at defending their core interests than in actually pushing for new things to happen. Although, the notable exception, I would say, to that is in the case of Alberta, the original proposal for APPs was actually brought to the table by the Medical Association. It's not exactly what it ended up being, but they were the ones that actually put the proposal on the table. And Alberta Health then tried to sell it to the political executive of the day, who wouldn't buy it because they couldn't see how it was actually going to save money. So there had to be a case made about how it was going to save money. And ultimately, the official announcement was that the doctors said they were going to find $800 million in savings elsewhere in the system. So of course, none of this ever materialized, but that was the argument that had to be made at the time, right? So again, it's kind of an example of how doctors are key to all this. I mean, I could give you a more recent example around primary care, but we'll maybe leave that for the discussion in a few minutes. So the conclusions then coming out of the book, and this is really just my sort of synopsis of the last few chapters of the book. Well, conclusion one, political leadership is necessary for reform. Those who stand to lose from significant reform tend to be able to resist and to minimize the reform, but they also lack the instruments and the political legitimacy to lead reform. So my comment a minute ago about how doctors are better at resisting change than actually promoting change, I think is something that we see applying more generally across all the cases that we saw, and I'm not speaking specifically about doctors. The existing vested interests in healthcare, all of them, or almost all, I'll say all of them, they have a vested interest in not really fundamentally changing the system, because all of them have to give up something in order for change to happen. And I'll get, when I get down to the end, you'll see that I'm not just talking about health professionals. So, conclusion two, Canadians who wish to encourage healthcare reform, regardless of policy direction, should be not ignoring the opposition political parties, because we saw that in the case where the province that achieved the most significant reforms by the measuring stick we were using was a province where there was an opposition party coming in and running on a mandate of significant health reform. They got elected and they moved ahead on that reform. So to think that you should only be targeting the existing government, well, in the case of Alberta, that might in fact be the case. However, in most other jurisdictions in Canada, you would be wise to be pitching your ideas to the opposition parties, not just to the government. Conclusion 3, big reform also requires public buy-in. To get this, there must be more transparency in decision making. There's also a need for institution building, and by institutions, I don't mean more hospitals, right? We don't have mechanisms in place for having a serious and significant conversation, societal conversation about the healthcare system of the 21st century and what it is that we as a society want and expect from that healthcare system, and what kind of trade-offs are going to have to be made in order to get to that system. We are still operating on basic principles and premises that were debated at a societal level back in the 40s and 50s. And I'm talking about in the last century, right? Some of us in this room may not have even been born in that last century. So that's a long time. And so society was different at that time. The demographics of the population was different. We're moving into a situation now where an increasing percentage of the population are going to be retired. Their healthcare needs are a lot different than the needs of a younger population. We need to have a serious conversation. It doesn't mean that the sky is falling. It doesn't mean that that the healthcare system as we know it is over, but it does mean that we have to do some serious rejigging of the system that we've got in order to be able to deal with what's coming up in terms of the needs of an aging society. And we have no mechanisms in place for that. We have a federal government at this point, political leadership in the federal government at this point, who thinks that healthcare is not even their responsibility, right? From their point of view, they write the check, and constitutionally the provinces have to deal with it, and the provinces are not of one mind about how to deal with it, right? So there has to be leadership, and it just is not there. And it's, unfortunately, the Canadian Medical Association, to give them credit, has put together, several years ago, a vision document. But really, they don't have the kind of legitimacy that a Prime Minister of Canada might have in terms of leading a national discussion about where the system should go. So it's not going to happen, even if the medical profession says they're ready to have that conversation. The federal government has got to step up and take responsibility for leading that conversation in the same sense that they did in the last century. That's the only way we're going to get going on actually changing the minds of people, or finding out what people want and moving them to that. So, conclusion 4, we've met the enemy and he is us. So I'm not talking just about health professionals, I'm talking about the public as well, because the public are just as much a part of the problem as the health providers and other interests in the healthcare system. Nobody really wants to do what's necessary to make the changes that are necessary, because it means that all of us are going to have to give something up. It means that people may have to, for example, pay more taxes in order to fund the level of healthcare services they want. And as we know, paying more taxes is a dirty word, particularly in this province. But just as a general trend, it's a dirty word. People might have to accept the fact that they can't see a doctor for everything that ails them, either because they don't need to be seeing a healthcare provider at all, because they need to take some personal responsibility for their health, or they could see another healthcare provider, such as a nurse practitioner, who could deal with their immediate needs, and if necessary, triage them onto somebody else, right? I've heard nobody in a position of authority have a serious conversation or do any advertising to try and educate the public that they don't need to see a doctor when they're sick, right? I haven't seen any big campaigns saying nurse practitioners can do just what doctors can do in a lot of cases. For primary care stuff, basic primary care, nurse practitioners can do it. We got, as Bob Evans, said years ago, we have shelves of research on nurse practitioners, and we need only look in other jurisdictions to see where they have used nurse practitioners effectively to do just that, right? So when people say to me, "Oh, gee, they seem to be doing better in Europe, and why don't we just adopt a model?" Well, you got to be careful with this. You might have to, use nurse practitioners. Why would we want to, use nurse practitioners instead of doctors? I said, well, maybe that's what they're doing over in Europe, and maybe that's why, it's not the only solution, but could be part of the solution, couldn't it? But here we don't even seriously talk about it, right? We're not seriously talking about these things. We're not seriously trying to convince the public about it. And to get to my earlier comment about another example where the physician veto was particularly effective around family care clinics. Family care clinics, we can argue about the political clumsiness of the way in which they were introduced. But family care clinics basically represented a direct challenge to the market monopoly of physicians in providing primary care. Bottom line, because the way they were originally pitched, they were not going to involve physicians. They were going to involve a range of healthcare providers. Doctors weren't even mentioned, right? Guess what the reaction was from the professional association? Guess what happened, right? We've got 4 or 5 of them, that basically were conversions of existing things that were out there. They're basically serving underserved communities in rural and remote areas, or in otherwise underserved areas. And I was watching the video. I was showing the video to my students in class the other day, the official AHS video that's out there now. And you look at the populations that are represented in those videos, right? It's like Aboriginal populations and immigrant populations. And I think they had one doctor in the video. They started with a mental health worker, though, and the doctor doesn't come in until much later, so it's kind of interesting. But doctors are now involved in these things again, right? So it's another example of where, true reform to the system, true reform, which would get these multidisciplinary things and just, get the job done, get these things in, get enough of them out there so you've got geographic coverage, so you've got 24/7 coverage. It's just not happening. And in the paper just today, the College of Physicians and Surgeons has finally twigged onto the notion that doctors are not providing after hours care like they should be. And they're finally saying they're now going to start clamping down. Well, great. I'm glad that that's happening, but the problem is not something that just suddenly showed up. It's been around for a long time. And we're only now starting to get down to brass tacks on this. And I'm glad that the profession itself is taking responsibility for this, because when I was involved with the Preferential Access Commission, I was, at one point I'm on a panel discussion with a doctor on both sides of me, and and someone from the college, I turned to the person from the college at one point and he said, I really would prefer to have the profession deal with these issues themselves, because I can't think of really any better way of having it done. But the profession has to start being more proactive, because I don't like finding out about this stuff when it turns up on the front page of the paper after all kinds of stuff has happened. I would prefer if the college was being proactive and out there and basically, enforcing the quality assurance and representing the public interest in a proactive fashion rather than just a reactive fashion. And I said, if it requires legislative change to give them the authority to do that, then let's do it, right? Because ultimately, if the profession is not willing to step in and step up, government will step in and do it for them, right? Regardless of which profession it is. So anyway, I kind of got off track there, and of course there's the book and a link to the book for anybody who's interested in it. Thank you.
Hey, well, thanks, John, and thanks for giving us a tour of a great volume for anybody that hasn't picked it up. I strongly encourage you to do so. We've got some time for some questions from folks that are here in the room, so I will, if you won't mind switching spots with me, come on over here, and then we also encouraging folks that are tuning in online or live or afterwards, use the hashtag Paradigm Freeze, and we'll try to read as many of those as we can for you. So questions or thoughts from folks in the room? I've got one for you as people are warming up. It's my prerogative as the chair. Where does the power of, and use doctors, we can talk about other professional associations as well, but where does their power derive from, right? So we talk about how maybe there are some institutions that are there that involve doctors in policy making, but what's the root of that power?
The root of power for doctors really is the societal bargain that has been struck and has been reinforced through policy legacies over decades and decades. So the original Medicare legislation, the original hospital legislation, getting rolled into the Canada Health Act, what was originally struck in that societal bargain really is the source of their power, and the source of that power is really the societal recognition at a point in time that there was an occupational group that had a level of expertise that was so specialized that the public itself did not have sufficient knowledge to operate on their own in that particular policy area. And they then had to enter into an agreement of trust. In other words, we had to delegate our decision-making authority to this occupational group, and the trade-off on the part of that occupational group is that they would make their decisions in the best interests of the public, that they would not be making the decisions solely based on their self-interest. And we see that reflected in the institutional arrangements, in the fact that we do have a college and we also have a professional association. And the professional association represents the private interests of the occupational group, and the college presumably represents the broader interests of the public in relationship to those private interests of the occupational group. So it's been structured that way from the get-go, and people have taken for granted that the doctors are making decisions in the best interests of the public. And I'm not saying that doctors are making decisions based on their own self-interest, but I think that there is a difference between the decisions that a professional association has to make on behalf of and representing its membership, and the decisions that a government has to make representing all the constituents or all the taxpayers in a particular jurisdiction. So it's a different kind of point of view, and also health professions in particular. And you could argue this for other professional groups, including professors, are making decisions based on the individual patient or the individual student that is before them at a given moment in time. And at an individual level, those professionals are looking at making the best decision for that individual at that given moment in time, regardless of what the broader consequences might be about overall societal allocation of resources. So it's two different perspectives that are happening there, but the original source of power really came through that societal bargain, and it's proved in the case of healthcare particularly resilient. Right, people still, when it comes down to it, and there's some major thing going on in healthcare, they're more likely to believe what doctors say than what politicians say.
I'm sorry to monopolize, but to challenge you on that point, I don't know whether we've reached a tipping point on this yet, but recent developments in the anti-vaccine movement, and we hear this now, discussions in and around the end-of-life care debate, suggests that maybe some of that part of this society's part of that bargain, the extent to which they trust physicians, as would they do with any sources of authority. We're about the decline of deference in society in general. I don't know whether we've reached that tipping point yet, but is your sense that we might be getting close to this bargain being readjusted?
I think that in a general sense, the part of what keeps that bargain in place is being able to continue to demonstrate that you have a mastery over a core body of knowledge that nobody else has access to. And one of the results of the revival of the internet in particular is that there's a lot of information out there now on healthcare, and an increasing amount of it is actually coming from the health science community itself. So it's out there, and people are going on the internet and they're arriving at their doctor's office armed with that information. And we can argue about whether the information is good information or bad information or accurate information or inaccurate information. But people are arriving now, and depending on the personality of the individual, they can in fact challenge what the doctor is saying to them. So you no longer have to automatically go for a test just because your doctor has recommended it, because you may have read something about, for example, a PSA test, a highly unreliable test. In at least one jurisdiction, Ontario, they no longer fund it, right? So when if you go to your doctor and they want you to get a PSA test, you might challenge them. You might challenge them and say, well, but that's a highly unreliable. And even if you get a negative result on that test, and they want to ship you off right away, for a biopsy or something like that, you might say to them, well, it's one test. It's a highly unreliable test, according to what I've read. And you're going to have to provide me with way more information before you're going to be sending me off for a more invasive procedure that itself has adverse consequences and may affect the quality of my life.
Yeah.
So not everybody is willing to do that, but there now is an environment in which that can occur, and previously that was not possible because the information was held close, right? Now the information is not held nearly as closely as it used to be. So I agree with you that the ground is shifting in a general sense, and we see that playing out in healthcare specifically. Whether or not we reached a tipping point or not in terms of renegotiating the bargain, I don't think we're at that point yet in healthcare, in part because there has not been another authoritative voice that has emerged to make the other arguments about things like, well, maybe we could use nurse practitioners to do primary care. We can go down the list of all the kinds of reforms that might challenge the central position of physicians or other health providers in the healthcare system, or might challenge the way things work for the public under the current system. Might require the public to be more responsible for their own health, for example, and have consequences attached to not being responsible. So we can go down that whole list, but whether or not, and I think this is kind of the point of our book, is from what we saw during that time period, and even projecting up to the current time period, we didn't really see enough shift in people's thinking to actually see that kind of tipping point happen. Which is why I come back to the argument that there hasn't been a serious societal conversation. Right? The Romano Committee did not really have a serious societal conversation. It was really about reaffirming the value of the Canada Health Act and the system that we had, rather than talking seriously. With the exception that there was discussion about some kind of national home care and some kind of national pharmacare, which, according to the consensus literature, are things that we should be seriously looking at because of the way our population is, the demographics are shifting in our population. But other than that, Romano was really pretty much a reaffirmation of the status quo. And at the time, it was because there was a significant push coming from the political right for making changes that would significantly, that would have introduced a lot of privatization in the system, basically.
Yeah, questions?
John, first of all, my compliments on the book. I mean, I think a lot of us are looking forward to reading this book. I'll take you back to 1993, 94, when, or around the time when Klein got elected, because definitely what you talked about did happen. And so we're actually having, and in fact, the paradigm shift that occurred was to regionalization. That's what it did. So I take you to today now. We have very similar circumstances with the price of oil and so on. And at the time, regionalization was a major shift. So today, based on some of the things that you're seeing happening today, what other alternatives would this health minister have around certainly some big changes that could occur? I mean, right now we're hearing, for example, 10% is the number that we're hearing in terms of cuts. Perhaps with the price of oil, it could be even worse later on down the road. But based on today, then it was regionalization. But let's take today. What are some of those options and alternatives that a government could do now around healthcare reform?
Fix primary care. Fix primary care. We've spent well over $1 billion across the country trying to incentivize serious reforms in primary care, and yet we have not seen the return. People still have trouble getting in to see a physician. They have trouble getting referrals. The wait times, Canada sucks in terms of wait times. There's no other way to put it. Compared to the rest of the world, we suck, right? For the amount of money that we have put into trying to reform these things, we should have the best damn primary care system in the universe. And yet we seem to have very fundamental issues still remaining that
What's
haven't
the
been
barrier
resolved.
to that? What's the barrier? Why haven't we been successful?
Well, the family care clinic example, I think, is a good one of, in my opinion, if you put in a system of multidisciplinary clinics across the province that were geographically distributed to provide coverage. So not unlike what Quebec did with CLSCs back in the early days. And you also ensured that you had 24/7 coverage involved in that, so after hours coverage, right? I mean, a good example of this is, last fall I was building a cross fence in my backyard for my pet rabbit so he could run around in the yard without escaping. And I managed to, I was using a drill and I managed to drill myself in the hand and I hit a radial artery in my finger. So I needed to get medical attention, but I, did a bit of internet Googling on the issue, and I, discovered that probably what they would do is they would, make sure that the bleeding was stopped. They might put a stitch in, depending on what had happened, and they do an X-ray. So it occurred to me, well, do I really need to go in an emergency room for that? The answer is no, because by that point I'd stopped the bleeding, I applied pressure, the bleeding had stemmed, right? I know that I could have gone to some sort of outpatient facility where they could do an X-ray. A family care clinic, in fact, could have done an X-ray and they could have dealt with it. So I get on the internet, start looking around. It's Saturday afternoon, 4 o'clock, start looking around for after hours care. Couldn't find anything. Right? So and I'm someone, who knows something about the system, right? So I'm thinking to myself, the average person, if they even went to the internet, and it took me a while to even look around and find stuff on the internet that gave me a sense of what was out there, and there didn't look like anything that was really viable. Not to mention the medi-centers didn't even look like they were open at that time. So ultimately, emergency room, the most expensive place in the frickin' healthcare universe to get anything treated, right? So I go there, I'm sitting around and I'm, looking at the people in the waiting room and it's packed, right? eventually they get me in, I'm sitting in there, and sure enough, they say, oh, well, we're not even gonna put a stitch on that because we just, we think it'll close up on its own. We're gonna send you for an X-ray. So while I'm sitting there, there's people on either side of me. The family on the one side of me, they had a teenage daughter that was going through some sort of teenage angst. And after they had sat in there for a while, someone came in and said, oh, we really can't deal with this here, but we can, send you to maybe see a psychologist if you want, right? So there was space number 2 being occupied in the emergency room. Space number 3 on the other side, a guy had done micro tears in his back. After he sits in there for a while, I say, oh, well, you've done some micro tears in your back. You're going to have to go home and ice that and take some anti-inflammatories for a few days and just take it easy. Could that have been dealt with outside of the emergency room? You bet. And then, recent poll that was done back a few months, which sort of confirmed my own little anecdotal observation. They were saying this recent poll is 40% of visits to the emergency room are unnecessary. And I talk to people on the inside and they say, oh, that's probably low. Maybe 60% of visits to the emergency room are could be dealt with in a less intensive, less costly setting. So I come back to my original point, fix primary care, right? Why we can't, it's going to require the government to, move forward and be committed. Coming back to one of the points in the book, it's going to require leadership. And if we do not have that leadership, it won't matter how many good ideas about reforming the system are out there, they will go nowhere. And you and I and everyone else in this room knows we've seen it over and over again where pilots get set up, good ideas get tested, and then they never go anywhere, right? So, and we're at a point now where we just can't afford to continue doing that and hope that something will eventually happen, right? So we got to have the leadership. Sorry, that's kind of a long answer, and it's only one example. I mean, there are all kinds of other.
But that's a big one.
And quite frankly, getting effective mechanisms in place for having meaningful input from all the stakeholders. One of the complaints, one of my observations about regionalization moving forward is they never have put in effective mechanisms for having meaningful input into the central decision making from some of the major stakeholders, including the community, and in particular the community, right? And we can argue, about whether or not, we can rely on the community to provide good input, or whether they're simply going to say, open more hospital beds, open my hospital. But there need to be mechanisms to be starting to have a conversation about things, and nobody is really given serious consideration to permanent and ongoing mechanisms for having those sorts of conversations, and to, trying to get everybody to wrap their mind around some of the emerging realities and talk seriously about what the trade-offs are. Even if we're talking, even the trade-offs about, if we were to go to more private healthcare systems, more like the US. What's the reality in the US, right? People have all kinds of myths about, how you get quicker access to care and better access to technology and this, that, and the other thing. But, that's not the whole story. And I think people really need to know what the whole story is, regardless of which policy options are being put forward. Not just the usual, well, we're going to dress this up to look real nice and hopefully it'll get picked to go to the dance. We need to, sit down and talk seriously about what all the options are. And as a society, we need to decide what trade-offs we're willing to make, right? And we don't see that conversation happening. Everyone runs for cover every time we start talking that kind of language. So anyway.
Other questions or thoughts? Yes.
So just kind of touching back on the variables associated with larger reform that you went into. I've noticed the majority of them seem to be very politically based. And kind of, I guess, drawing on what you were just saying, thinking about that a little bit more, what do you think are the opportunities from within individual, say, departments of health in order to be able to kind of create the conditions or to have the, I guess, the opportunities for change that are more internal to departments as opposed to this external work, of course.
I think that, and this just doesn't apply to healthcare, you know, it's been my observation that leadership sets the tone, right? In any organization, any large complex organization, leadership sets the tone. They send messages either implicitly or explicitly to everyone who works in that organization, what the expectations are about the direction of that organization and about what acceptable behavior is inside that organization. So if we do not get effective leadership, leadership that's committed to, you know, fundamental change according to best available evidence, we're never going to get there. So people in the department can, you know, give their all to move things forward without necessarily having the expectation that it's ever going to go anywhere. And, you know, when I arrived in Alberta, it was sort of the tail end of an era in the public service when, you know, public servants with, you know, significant experience on a particular file, they often had longevity, they often had expertise in the area, could provide information to politicians with a reasonable expectation that the politicians were likely going to take their advice. I don't think that that would accurately characterize the public service the way that it currently is. And feel free to correct me if I'm off base, you know, if I'm armchair quarterbacking on this, but I haven't become that detached from the public service or people in the public service that I think that I'm mischaracterizing the general shift that has occurred. And if you look at, you know, the literature on new public management and new public governance in particular, that broader literature seems to sort of bear out that characterization that I'm putting forward. So you know, to answer your question, I think the opportunities for doing it from inside, if there isn't, you know, a clear receptiveness at the leadership level, or if you aren't getting clear signals from the leadership, then I'm not sure it's going to happen, right? I mean, Alison Redford, you know, we can say what we want about her as a political leader, and I've heard lots of things, and I've made some comments of my own publicly about it. But when I saw the family care clinic thing being put forward, I thought, yes, finally, we may be looking at some kind of fundamental change in the healthcare system. They even sent a message to Fred Horn to the same effect. They said, you know, Fred, on the right track, please keep going. So that was a message that was sent out from the leadership about that as a direction. So there was an opportunity there, but I don't think it was implemented particularly well. Coming back to, you know, the idea that a conversation needs to happen with the public. If you're going to make a fundamental change like that, before you do that, you need to have a lead-up campaign to actually educate the public about the benefits of doing that. So all of a sudden to say, oh, we're going to have this new model, and doctors aren't going to be involved, right? And just leave it at that, right? What's the public, you know, the public school, what are they going to do? Their head is rotating over to look at their doctor. What do you think about that? And what's the doctor going to say? Well, nurse practitioners, and we're not going to, you know, we're the ones that are the most qualified. So, you know, implement, as the literature says again in public policy, implementation is everything. So, you know, that was an example of what in my opinion was a good policy idea, which is well supported by existing evidence. You know, we've had models like community health centers that have been around forever and a day, which over time have demonstrated through research that they provide comparable care to other, comparable if not superior quality care to other models of primary care, and they cost the system less, right? We have evidence We didn't used to have good evidence on it. We had some evidence, not good evidence. Now, because of the research going on in Ontario, we have good evidence, right? Comparing all the different models, CHCs fit in there, you know, a multidisciplinary way of doing things, getting the right patient or the right care to the right patient at the right time. You know, that was the mantra that Stephen Duckett was throwing out there. I don't know whether he had ended that or he was borrowing it from somebody else, but you know, that's kind of the mantra, and things like family care clinics are an example of how we can make that a reality. And it covers off all the things that the government says it wants to do. So getting integrated health records, you know, in real time within the practice, getting a team of providers around the table with you know, around an individual patient, having one-stop shopping for the patient, and having after-hours coverage. So why are we not rolling that out across the system? Well, it comes back to, you know, the point that our book makes, is that the solutions are out there, right? The ideas are out there, they're well known. It's the politics that we have to get around. So we have to stop thinking about things just in terms of, you know, this is a great solution. We have to start thinking way more about the larger political context and how we can change that, you know, as they say about drinking and driving, change the conversation, right? If we had a campaign in healthcare, change the conversation, right? Maybe that would be a good starting point. But we do need to have that conversation to change the conversation, or else you guys are just wasting your time in the ministry. In my opinion, anyway. Not for lack of effort, though, right? Yes.
Time for one
I
question.
was wondering if you could expand on your point regarding the federal government's role in this. It seems since 2004, Paul Martin's kind of First Minister's Conference on Healthcare, we've kind of shifted away from federal government being involved in outcomes to more, well, no other government has increased health premiums to the provinces more than our government has. And it seems to be a focus on just delivering more and more money to the provinces and let the provinces deal with it. So why is there a role in, like, why is the federal government, their role in this is important? Why is it important if provinces are delivering healthcare? Why is the national government role in this important?
Well, why did the national government have a role in the establishment of Medicare? Because we needed some sort of national consensus on the healthcare system that we wanted to provide, so that we could have some sort of standardization of the care that was going to be available to all Canadians, right? And again, we can argue about how much of a myth versus a reality the standardized availability of care is, even within the province, you know, rural versus urban, right? I mean, my reason for becoming involved in the public inquiry was around the Rimby people who were driving down a dangerous road to try and get in for treatment for kidney disease, right? Kidney dialysis, right? So clearly, the people in Red Deer were getting better access to that treatment than the people who had to drive in from Rimby, right? So the reality is that we don't have standardization, but the reality also is that we have a sufficient level of comparability across the different jurisdictions in this country to be able to say with some confidence to Canadians that nationally, you know, whether you're accessing services in Ontario or Alberta, you're going to be accessing services in a similar or a comparable fashion, right? At least at the time that was put in place. We could say that now things have, you know, been kind of going off the rails increasingly as time has gone on. Things have become more complicated, but that's why we need the federal government. We need the federal government to lead that conversation with the provinces, get everybody around the table, and have a public conversation about the system of the 21st century. Because if we leave it to individual provinces, what Ontario does, Alberta might not do, just because it's not a made in Alberta solution, and vice versa, right? And of course, Quebec may never do anything that anyone else does, just because Quebec wants to maintain its distinct identity. But at least in the case of having the federal government involved, the federal government can help to smooth some of those things over, right? To come up with that vision and to get, it's not an easy process, right? The Constitution, the Charter of Rights and Freedoms was not an easy process. But at the end of the day, right, they were able to come to some sort of agreement that involved numerous compromises, but they were able to come to some sort of agreement. That's what the federal government needs to do in healthcare in the same way that they did it in the last century.
Thank you, John, for joining us here today. That was a fascinating discussion that started off at the 40,000-foot level. We delved down into your experiences in emergency rooms at the 10-foot level, and then back up again. We covered, again, a tremendous amount that's covered in your co-edited book. I recommend it to anybody who's interested in not just healthcare reform in Canada, but as you touched on, the intersection between politics and public policy and policy reform in general. I think it's a great lesson for folks that are looking to learn more about that. So again, thank you everybody online for joining us. Find out more information about upcoming events, including one that we have coming up at the end of the month through IPAC Edmonton as part of our Road to 2015 series. We're at 2015 now. We're talking with experts from the polling sector, from academia, and from journalism about what we can expect on the road to the 2015 federal election. All bets are that it's in October, but who knows? So see our website for more information about that. You can always follow us on Twitter at IPAC Impact. And we hope to see all of you again soon. Thanks a lot.